and Stanton here with ACEP Frontline, joined today by somebody who doesn't need much of an introduction, considering he's the voice and face and representation of probably one of the greatest representations of education on the emergency medicine platforms. And last time we talked to him was actually about how he got into EKGs with an actual initial interest more in geriatric emergency medicine and medicine in general. But Dr. Amal Mattu, currently tenured professor, vice chair, and director of faculty development fellowship and co-director of the Emergency Cardiology Fellowship for the Department of Emergency Medicine at the University of Maryland School of Medicine. And so we wanted to catch up with him again today. We'll talk about, one of the reasons here in just a little bit, but there's always a good reason to have conversations about EKGs, about cardiology, about the things we face every day. And if your department is anything like mine, you're seeing hundreds, potentially hundreds of EKGs every single day. And so we will kind of roll through some of that, some of the things to fine tune your skills, and then some of the pitfalls we see as well. So Dr. Mattu, thank you once again for joining us here on the Frontline.
Well, thanks, Ryan. It's great to be back.
So, I think just to mention, every one of us is seeing a ton of EKGs every single day. They slid in front of us. They come from every single angle, and it becomes very easy to get a little bit numb to those EKGs as they come in. If you get physicians out there, especially those physicians that are newer into practice, especially getting to community medicine where, may just be you in the shop and you're getting all of these EKGs coming in, how do you maintain and manage that EKG attention, avoid the distraction, or that crying wolf kind of idea of every one of them so far has been normal, so this one is probably going to be normal too?
Well, that's a tough question. I wish I had a simple answer, but I think there's no other answer than to just say that you've got to take a moment to look at every one of those 12 leads, and you need to ignore the interpretation at the top. I think that's one of the problems that occurs, that when you start getting multiple EKGs thrown at you, the temptation is to just immediately look at what the computer says at the top, and then maybe not really take a close look at the EKG itself and just rely on that interpretation. That can lead to some real disasters. Not too often, but those disasters really stick out. And as you kind of alluded to earlier, a disaster in emergency cardiology oftentimes results in permanent disability or loss of life. So I don't have any other solution but to simply say that you've got to practice, and you've got to take 20 or 30 seconds and really look at every one of those 12 leads. There's just no other way around it.
When you were educating your residents and others in your department, do you have them? Because when I started up, we first said just cover everything, cover the top 2/3 where all of that interpretation and stuff is. Do you encourage your folks, especially students and new residents, just to cover that up, get their interpretation first, and then maybe cross-check to make sure that there's not something that they missed or need to take another look at?
Sure. In the ideal world, the answer is yes. Practically speaking, when things get really busy, then it's often tough to do. But ideally, to the greatest extent possible, you have your residents or students take a look at that 12 lead with the top covered up. What sometimes I'll actually do is I'll just take the EKG over to the copy machine and make a copy of it with the top part removed or blanked out. And so they have no other choice but to look at that EKG without an interpretation and really come up with the answer. And it's important to do that even with the normal. So I'll tell them up front that even though I'm covering the interpretation here, don't assume that means that something's abnormal. You need to learn about normals as well. Now, during really, really busy shifts, that doesn't always happen. But again, in the ideal world, you should try to do that as much as possible. And you really learn a lot more about reading EKGs if you do that.
I felt like recently, especially working in our emergency department with a lot of referrals from the walk-in clinics, you have a lot of people who didn't get adequate training in the interpretation of EKGs, sending stuff based on that top read. getting the patients really worked up and scared that something bad is happening. People, perfectly asymptomatic people, just getting an EKG for an annual exam that doesn't show any changes, but the person doesn't have the experience to compare or to read it, sending that in. Is that something that you're seeing, that with the explosion of folks that may not have as in-depth training in cardiology and EKG interpretation are making diagnoses based on the top of that, and referrals for people who honestly don't need it?
Absolutely, all the time. We've had patients sent in even from other emergency departments. For one example I can think of in particular was a patient that got sent to our emergency department on a transfer because of presumed new onset atrial fibrillation, and that was based on the interpretation at the top. But when you actually look at the EKG closely, the patient did have P waves with every QRS only visible in lead V1. And so this patient essentially got transferred over for normal sinus rhythm. And the presumption was this is new onset AFib. The patient needs to be admitted to cardiology, anticoagulated, and in the end, the patient ended up just being discharged home. So this happens from emergency departments. It happens from urgent care centers, from doctors' offices. And it's not an isolated thing. It doesn't happen every day, so I don't want to overblow it, but it happens often enough that it's a nice reminder that I think everybody in every specialty really needs to work a little bit more on their EKG interpretation skills.
Well, if you've got a test, you need to know how to interpret it. We were always taught that in residency. Don't do the test unless you know what you're going to do with the information once you get it. And EKGs are so easy. It's a non-invasive test. It doesn't require a blood stick. But is the person you're going to hand that to going to be able to interpret it adequately? Because just as we're talking about here now, the potential for overcalls. What about the finer points of potentially undercalling or missing something that does have a significant potential long-term threat for the patient? So let's roll into that from a physician standpoint, whether it's the young docs, the weathered attendings, folks you work with in your department. What are some of the biggest pitfalls that you see in the approach to the EKG? And we know that, looking at the top right off from the beginning and assuming that's the gospel is one of them. But what are some of the things that you see kind of recurring pitfalls that may catch us up in the emergency department?
Well, I think, again, that over-reliance on the interpretation of the top is just so common, and that probably accounts for the vast majority of the pitfalls that I see. Also, when that interpretation says the word non-specific, remember, non-specific is not normal, and the way the machine is programmed, it oftentimes, typically it'll read something as non-specific if there's less than a millimeter of ST deviation. So, for example, you could have an acute coronary occlusion and have ST elevation of 0.9 millimeters in V1, 2, 3, 4, 5, 6, big anterior MI with LAD occlusion. But if it's not 1.0 millimeters, your computer will call it nonspecific. And the same thing applies to ST depression. So you need to be very careful and really scrutinize that 12 lead and not blow off ST elevation or depression that's less than a millimeter the way your computer will. A couple other things that oftentimes are missed, which I don't think are necessarily within the standard of care to know about, but I think emergency physicians and certainly cardiologists are getting better and better and better at picking these up. It's not just a matter of ST elevation or depression, but we're starting to understand over the past few decades that when a patient has an acute coronary occlusion, the first thing that happens is actually not ST elevation or depression. The first thing that oftentimes happens is the T wave changes. We've all learned about the term hyperacute T wave, meaning tall and broad-based, but there's a lot of things that give you tall, broad-based T waves. Young people with LVH or high voltage will oftentimes have that. Benign early repul can have tall, broad-based T waves, left bundle, and so on. So the tall, broad-based T waves, I don't like to think of that as hyperacute. What I like to think of hyperacute or early ischemic T waves are when the T wave is so large, number one, when the T wave is so large, you can fit the entire QRS complex inside the T wave. So when the T wave becomes larger than the entire QRS complex, that's got to be thought of as ischemia until proven otherwise. And then number two, the morphology of the T wave. Normally the initial upslope of the T wave is nice and concave upwards and gentle. When that initial upslope of the T wave becomes very straight in appearance, to me, that is ischemia also, regardless of the height of the T wave. When the initial part of the T wave looks very straight, I worry about early ischemia. Now, with both of these two things that I just mentioned, the number one, when the T wave is larger than the QRS, number two, when the initial part of the T wave is very straight, with both of those, I'm thinking ischemia. That doesn't mean I'm activating the cath lab, but at the very least, what I'm doing is getting repeat EKGs over the next half hour or an hour. And if those evolve, then you just picked up an early ischemic patient. If they don't evolve, then I'm not going to worry too much about it. But those are early tip-offs. And then the one other early sign of ischemia that I think people are learning about, again, I don't think this is necessarily standard of care to know about, but more and more emergency physicians are learning about this, is early reciprocal changes. And the classic example is AVL. When somebody's having an inferior wall STEMI, oftentimes they'll develop reciprocal changes in AVL, manifest essentially as a flip T wave and ST depression. Well, decades ago, Marriott and some other EKG gurus talked about this, that they said when a person has an acute coronary occlusion of a vessel, let's say the right coronary artery, before they even develop ST elevation in the inferior leads, the first thing that often happens is a new flip T wave in AVL. So if somebody's got ischemic sounding chest pain and a new flip T wave in AVL and nothing else, that could actually be the first sign of an impending inferior wall STEMI. So when you see that type of thing, also get a repeat EKG in the next half hour or an hour. And if nothing changes, fine, you're done. But so you will pick up some of those turning into STEMIs. And I've got dozens and dozens of those cases that have been sent to me by people everywhere. So there are some subtleties that go beyond just looking at the ST segments. You need to look at the morphologies of the T waves. You need to look at the height of the T wave. And you also need to learn about reciprocal changes that may precede the ST changes.
That's some good nuggets right there, folks. That's you're going to need to put that on playback and listen to the last 5 minutes of this podcast over again, because you got about 4 or 5 key tips right there talking about the early changes in the T waves, the larger T waves, which for most of us was driven in that a big old T wave is you just need to start thinking about hyperkalemia as opposed to a potential early changes associated with ischemic. The ST changes morphology as well as your early reciprocal changes, some keys right there. And you actually bring up one of the most important things that I think people need to make sure that they consider with all of the EKGs that we get. If you've got one you're concerned about, don't worry about getting another one shortly thereafter, waiting 5 or 10 minutes, or if there's a little bit of artifact there. It seems now more and more, especially if a machine's getting on the back end of its career, you got some ectopy and some artifact on there that you need to get clarified. So don't be afraid to get multiple EKGs. And I've done that many times before, 10, 20, 30 minutes, repeating them, not having to wait for that 1 or 2 or 3 or 4 or however long your hour rule out period is. Just don't be afraid to get another EKG to compare exactly what you were just talking about. And then that importance of, some abnormal things are going to be normal for that patient. So being able to compare those to the previous EKGs to see that little bit of subtle change, a little bit of non-specific change, maybe that's pretty typical for that patient, but also, that may be a new variation or a new change since our EKG that was done a few years ago. And I assume that's one of the big things, especially now with the electronic medical record and the ability to view EKGs from days, months, years past, that you really push with your residents and other attendings as well to make sure they do that comparison study.
Yeah, definitely. If the EKG that you get is abnormal and the patient has any type of concerns with their chest pain, then it really is important to spend those extra few minutes to pull up an old EKG. And now with the electronic medical record, usually it is really nothing more than just a few minutes. And again, I don't want to overstate this. We're not doing this for every single patient. But if the patient has some concerns in their history, their HPI or just the way they look, and that EKG is not pristine normal, then I think you should take a few extra minutes and get the old EKG for comparison, because that can really make a big difference in their disposition.
Well, and if you're in a situation like this, and if a lot of EKGs are done when they're not necessary. So the patient who comes in with an ankle pain because they got a twitch in their side, all of a sudden they now got an EKG as well. But if you're going down that cardiology at all evaluation pathway, you got to do that comparison to look, because if you miss it, somebody else is definitely going to make that comparison as well. But also making sure that the one you're comparing it to is not from their last heart attack. It looks the exact same, so it must be normal. Well, the last one they had was from their last MI, or when they last had to have a stent. It was, you got two abnormal times as well. I had that multiple times through residency. People, the only time they got their EKGs is when they needed another stent, so they all look the same. They just needed another stent at that time. When let's, and one reason we want to talk is, and you've got all these cases and stuff, and you do all of these educations, and you've got your page where it comes to being out all the cases reviewed and looking and digging deep into them. But also, you guys have recently just redone in every book. If you don't have an Amal Mattu EKG, an emergency, acute, or critical care guide, you probably, there's a few books out there, but I think most people, especially in emergency medicine, have dealt with your books. And you've got the new one that just came back out, that you edited, the Amal Mattu, Jeffery Tabas, and William Brady. The second edition of this book you released in 2007. Is there what's new, and what have you added? What did you change in there with regard to the second edition?
Sure. So the second edition just got published within the past month, actually, and I'm really, really proud of this book. I think the folks at ACEP really did an amazing job in terms of the publishing quality and the editing. There's a few new things about this book. First of all, we've added a lot more, especially high quality EKGs. The first book had quite a few EKGs, but they were generally placed at the back of the chapter. With this one, ACEP actually hired an artist to make a uniform vision for all the EKGs and touch up all the EKGs. So they all are just unbelievable in quality and appearance, number one. And the EKGs have all been placed within the text rather than being pushed to the back. A lot of new cases have been added on. We've gotten a few new authors and completely rewritten from scratch some of the chapters to make them even better, including some of the ischemia and mimics chapters. There's a handful of updates that we know more now than we did in 2007 with the first edition about things like Brugada syndrome and Welland syndrome. We've added in some findings that we've just talked about, some of the subtle ischemic findings that people need to be on the lookout for that we really didn't know about in 2007. There's a few brand new things also. There's more about the revised Scarbosa criteria with left bundle, and also one of the newer concerning causes of syncope, arrhythmogenic right ventricular cardiomyopathy, or ARVC. That's been added. We didn't know anything about that back in 2007. So, a lot of times we think of EKGs as something that really doesn't change. It certainly doesn't change as rapidly as, say, guidelines in emergency cardiology and infectious disease and so on. But there are definite, very, very important changes that have occurred in electrocardiography over the past 10 years. And that's why we really thought it was important to get this new edition out. And I think it really hit the mark. So I'm very proud of what we've got in this second edition.
Well, several of the case reviews that you have done and educations, and in fact, I was had you in a review course here a few months ago when I was getting my boards redone again. They were some of these little tidbits, some of these little things are huge. Every day I'm educating our paramedics on the Scarbosa criteria, because the way the monitors print out, it's hard to see some of the depth and degree of the QRS complexes. And so getting that Scarbosa's criteria so they can be a little bit more accurate when activating the cath lab. With Welland's, it was huge. We've seen that quite a few times recently and been educating with that as well. So some little things that you can look at. But one thing that has changed since I started in residency about 15 years ago was, at that point, the left bundle branch block, the new left bundle branch block was a don't pass, pass go, don't collect $200, whatever, straight to cath lab type picture. What happened to that, and how is it now from the cardiology standpoint been that's an important little point, but we're not going to go to the cath lab right now.
With the revised Scarbosa criteria or the original Scarbosa criteria?
Well, either way, I just don't. Anytime somebody comes in now with that new left bundle branch block, that I don't recall, cardiology being in any hurry to take any of them to the cath lab.
Yeah, that's actually one of the additions to the book also. Back in 2007, we were all operating under the prior guideline, which said that if somebody's got chest pain or appropriate symptoms and they have what we consider a new left bundle, the guidelines all said that should be assumed to be a STEMI. And the cardiologists oftentimes would kind of shrug their shoulders and not worry about it. And that's because the cardiologists knew back then that most patients, the vast majority of patients with the new left bundle, actually don't have a STEMI. So finally, research was done and verified what the cardiologists already knew, that if patients have chest pain plus a new left bundle, they are no more likely to rule in than patients with chest pain and old left bundle versus patients with chest pain and no bundle. Instead, what we now know is that if a patient has a left bundle, when should you worry? Number one, you should definitely worry if they've got the Scarbosa criteria. And number two, you should definitely worry if they are hemodynamically unstable. So in either of those scenarios, the new proposed guidelines and algorithms and cardiology literature says if somebody has a left bundle, who cares if it's a new or old left bundle? But if somebody's got a left bundle, when should you worry? Number one, if they're hemodynamically unstable, then get on the phone with cardiology or even consider lytics. Or number two, if they've got Scarbosa criteria, call cardiology or give them lytics. And that seems to be what the best literature has shown. And in 2013, the US guidelines, the ACC/AHA guidelines changed and got rid of new left bundle. And the new guidelines really have indicated and followed through on the literature saying that new left bundle in and of itself, by itself, is not a huge concern.
As we kind of get close to the end here, is there any, you're always such a wealth of knowledge when it comes to the EKG standpoint, the cardiology standpoint, honestly, a lot of other things for that matter. But, this is your avenue now with the EKG standpoint. Would you recommend to docs as they get out into the world really to up their EKG interpretation game? Because it's one of those things that initially, you're trying to learn the basic rhythms, basic changes, and the in finding STEMIs and that sort of thing, and looking for little wave things. But when it's that next stage, going to an advanced stage of interpretation, how do you recommend folks kind of make those steps, make those movements, and really become more proficient on their practice?
Well, I think the last thing you said, the last word you said is the key. Practice, 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 practice. That's what it all boils down to. There's actually some nice articles out there which have looked at how accurate cardiologists themselves are, experienced cardiologists themselves are at diagnosing STEMI and distinguishing STEMIs from the mimics of STEMI. And those articles have consistently shown that while cardiologists are great, they're not perfect. And so you can't assume that you don't need to know this stuff and you can just rely on your cardiologist to make every diagnosis, because cardiologists out there differ in terms of their skills as well, just like emergency physicians do. When they've actually compared the skills of emergency physicians versus cardiologists, what we have discovered is that the very best EKG interpreters are not necessarily distinguished by what certificate they have on their wall or what fellowship they did or what specialty they have or what board exam they passed. It turns out that the greatest predictor of how good you are at reading EKGs is how much experience you have at reading EKGs. So people that have been out and been practicing this and looking at thousands of EKGs are simply better than people that are not practicing and are not looking at lots and lots of EKGs. So the more you practice, the better you're going to get. And that can be an emergency physician. It can be a cardiologist. It can be a pre-hospital care provider. There's some fantastic pre-hospital care providers out there that have written some great books and run some fantastic websites. It all boils down to not who you are or what specialty you're in. It really boils down to simply practice, 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 practice. And the more you practice in this specialty, the more lives you're going to save. So it's a big, big deal.
Dr. Amal Mattu with the book Electrocardiography in Emergency, Acute, and Critical Care. second edition just released, available in the ACEP bookstores. Fantastic reference. I'm going to definitely have that in my emergency department reviewing as well, and help with education with my students, because I cannot even think to compare with any type of interpretation as you're going to be able to provide. But completely agree with the experience being the big player and getting to see things normal and abnormal. So Dr. Mattu, thank you so much for your time and joining us here on Frontline.
Brian, thanks so much for your time.
As always, if you get a chance to see Dr. Mattu do a talk, they always fill up early, at least at the ACEP conferences. I'm sure at any place he speaks are the same way. Make sure you get in there, because I've been fortunate enough to enjoy several over the last number of years, and really does, more importantly, really explains it in a way that folks like myself that really can't necessarily figure out the electrophysiology quite as well can really understand, and really puts it into context and some good pictures. And so check that out if you can. Check out the book. We need to be the ones, as emergency physicians, as our PAs and nurse practitioners, we need to be the ones that can really do some of the best interpretations, evaluations of EKGs in the emergency department and even in the acute care setting, with the context of the patient presentation as another data point, as something to use to guide us in our evaluation, management, and disposition planning for our patient. As for me, you can contact me at youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com. That's at everydaymed on Twitter. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.